Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to participate in this prestigious conference. I've been assigned a difficult task to speak about the endpoints in adjuvant trials in immunotherapy and targeted therapy. In fact, when I saw the topic, I thought I'm going to participate in a debate, but fortunately, it's not a debate, so I can speak from both the sides. And finally, you can decide that which is a better way. So when we look at the clinical trial endpoints, particularly for adjuvant treatment, the commonly used endpoints in various clinical trials are overall survival, disease-free survival, and recurrence-free survival. There are certain more modifications which are used commonly in adjuvant setting, like invasive disease-free survival, metastatic disease-free survival, and so on. I'm not going into details and definitions of these endpoints. But as a clinician, when we decide about the adjuvant treatment, what are the considerations which we need to keep in mind? The first and foremost is certainly the efficacy of the treatment. And the ways to assess the efficacy of a new treatment modality, the gold standard has been overall survival. There have been surrogates for overall survival, which many of the clinical trials have used, are disease-free survival and recurrence-free survival. So that determines how efficacious is the treatment. Next, and the very important aspect, and more so in the adjuvant setting, is quality of life and the patient-reported outcomes. On the contrary, in the metastatic disease setting, when we use a toxic treatment, but if it's effective, eventually it reduces the disease-related symptoms, and there can be improved quality of life despite using a toxic treatment. But on the other hand, when you're using an adjuvant treatment modality, the patient is disease-free when you're using the treatment. And if the treatment is toxic and it has to be used for longer duration, there are certainly considerations like quality of life, and we need to be careful about them. Cost is certainly an important factor when we decide about any new treatment modality. And it's even more relevant in this era of targeted therapies and immuno-oncology drugs. There is a risk of over-treatment. When you're in your control arm, not all the patients are going to recur. So if the overall risk of recurrence is low or is a small risk of recurrence, there is a larger proportion of risk of over-treatment, because many of your patients are being unnecessarily treated. The next and important thing which we need to assess whether the relapses in that particular disease settings are salvageable or not. Do we have effective subsequent line of treatment, and how efficacious those treatments which can be used subsequently? And that can actually help us in deciding whether we need to use that particular treatment in the adjuvant setting, or can we use it subsequently if there is no difference in long-term survival. Disease-free survival has been used for a long time as a good surrogate for overall survival. And in the era of cytotoxic chemotherapy, it has been proven to be as a reasonably good surrogate. But this is questionable whether the same way we can use DFS as a good surrogate for immunotherapy, and even more questionable for targeted therapy. We do not have such evidence yet. There have been several successful examples when targeted therapies have shown that disease-free survival improvement had translated into an OS benefit. One of the best example I could quote is use of adjuvant trastuzumab in HER2-positive breast cancer, which, although the primary endpoint of the trial were disease-free survival, but subsequently it showed that the disease-free survival benefit eventually translated in overall survival advantage. But there have been some some famous failures also, and one of the best examples for that is use of 1-year adjuvant imatinib in resected GIST. In the initial trial, when the imatinib was used for 1 year in adjuvant setting, it showed an impressive hazard ratio of 0.35 in terms of recurrence-free survival, but this trial failed to improve the overall survival. And more recently, this European trial, which has a reasonably long follow-up period, although showed an improvement in recurrence-free survival, but it again failed in demonstrating an improvement in overall survival. But subsequently, when 3-year imatinib was used and compared against 1-year adjuvant imatinib, and this updated result shows that it not only improved recurrence-free survival, but also resulted in improvement in overall survival. Highlighting that it's not probably just preventing the recurrences, it's delaying the recurrences, as evidenced by more recently published data of 5-year use of adjuvant imatinib and resected GIST, which is probably even better. So the optimum duration is probably not yet known, and that is influencing the long-term outcomes. Adding to this list of controversy, this recently published adjuvant CTONG trial, this Chinese studies, which compared the use of adjuvant gefitinib as compared to platinum-based doublet and resected non-small cell lung cancer with EGFR mutation, which initially showed an impressive improvement in disease-free survival, but on subsequent follow-up failed to demonstrate any overall survival benefit. Adding to the list is adjuvant sunitinib in high-risk RCC, which showed an improvement in disease-free survival at the cost of toxicity with dose reduction requirement in almost 1/3 patient, half of the patients requiring dose interruptions, and on almost half of the patients having grade 3 and 4 events. But on subsequent follow-up, this trial also failed to demonstrate an overall survival benefit. There's a list of immuno-oncology trials in adjuvant setting, which has demonstrated improvement in recurrence-free survival and disease-free survival in melanoma and RCC. But so far, we do not have data of mature overall survival data demonstrating that there is an overall survival benefit. Similarly, in resected non-small cell lung cancer, the SciEmpower 010 study, which demonstrated an improvement in disease-free survival and a mature overall survival data. Also highlighting that probably a class of patients are benefiting more even in terms of disease-free survival, that is patients with high PD-L1 and higher stage of disease. And if you look at the list of the immuno-oncology trials where IO drugs are being used as adjuvant setting, most of the trial are using disease-free survival as the primary endpoint, except a few, like one is for highlighting is Alchemist IO trial, which is keeping an overall survival as a co-primary endpoint. Otherwise, most of this industry-sponsored trials are keeping disease-free survival as the primary endpoint. And one of the most discussed trial in last 2 years is ADAURA. And probably maybe one of the reasons that this topic has been kept in this particular conference. If you look at the disease-free survival advantages, this a very impressive hazard ratio 0.17, which is hardly seen in any of the oncology clinical trials so far. But I would like to highlight here that you are looking at this trial a bit early. This is a 3-year treatment, and you are looking at this trial at a follow-up of median of 2 years, where many of your patients in active treatment arm are actually on ongoing treatment. And we need to look at the situation when they stop the treatment, what actually happens. So far, OS data is pretty much immature, and the curves are practically overlapping.
1 minute left, sir.
Yeah. So, again, I would like to highlight that we actually need to, whenever we see that a trial reporting as a benefit in terms of disease-free survival, we need to see whether the overall survival is improved. If overall survival is not improved, we can actually have this shared discussion with the patient that probably we can use this treatment subsequently. If the OS is improved, we again need to see whether the patients in the crossover has been allowed in this particular trial or not. If the crossover has not been allowed, then the possibility that the overall survival advantages which we are seeing is just because the patients in the control arm have not received the effective treatment. And if there is, despite crossover, there is a good overall survival benefit, that's the situation probably we can take the definitive decision and that the treatment is really beneficial. So having said that, all these endpoints are actually kept as a priority in the different settings. If you have a pharma-sponsored or a regulatory trial where the primary aim is to get the drug approved as early as possible, Obviously, these trials would keep the early endpoints, which are easily achievable, like disease-free survival or progression-free survival. But here, the endpoints generally they are dependent on the type of and timing of measurements, and which confers a bias in terms of assessment. And the one best example for this kind of trial is ADORA. On the other hand, an academic trial which is trying to answer a pragmatic question would probably keep the most hardest endpoint with an easily measurable ways, which is overall survival. And overall survival is not cannot be influenced by any type or timing of assessment because that is the universal truth. And one of the best example for these kind of trial is Alchemist. Both these trials are trying to answer the same question, but when we have the early results with Adora and with those impressive results, the trial has been stopped early. On the other hand, the Alchemist trial is still ongoing with a proposed sample size of almost 6,000 to 8,000. And these are the kind of the ideal world scenario kind of endpoints in Alchemist trial. But unfortunately, we don't live in the ideal world. There have been, if you see in last 1 decade, there have been very few good academic trials which have had big influence on our clinical practice. On the other hand, you have had plethora of industry-sponsored clinical trials in last few years. Again, I'm not trying to influence you which endpoint to use for your therapeutic decision making in day-to-day clinical practice. But what's more important that before you take these decisions, you just try to answer some of these questions which I discussed in previously, and choose the best treatment and choose the treatment more wisely. Thank you very much.